Hello, this is Farah Douglas, President and CEO of the Liver Health Foundation. Thank you for joining us tonight. Liver Health Foundation is a California-based entity. We are a nonprofit 501c3 organization representing millions of liver patients in California. Our governing body is our board of directors, whose members represent liver patients and caregivers. Our guiding light is Liver Health Foundation's Medical Advisory Council, chaired by Dr. Sami Saab from UCLA, which has 37 members who are some of the best hepatologists and liver surgeons in the United States. Our mission is to provide updated and accurate information on liver health, promote prevention of liver disease, advocate for equity in access to healthcare, and host community and physician-centered educational programs such as this one. To register for our upcoming programs and events, please visit our website at liverhealthfoundations.org. This week, April 23rd through 29th, is National Pediatric Liver Transplant Week. To honor this occasion, tonight's webinar is about pediatric liver transplant. When children's and teenagers' lives are in danger because of a diseased liver, or when infants are born with a serious liver disease, liver transplantation may be the only option to save their lives. I know we don't often associate kids with liver disease, but in 2020, 502 pediatric liver transplants were performed in the US. During the same year, 616 new names were added to the waiting list for a suitable liver. Our experts tonight will bring more clarity to the subject and will offer accurate information. Tonight's program has been made possible by a grant from Albireo Pharmaceuticals. We thank Albireo for supporting our efforts on behalf of liver patients. It is now my pleasure to introduce Dr. Nesreen Sufi, who has generously accepted to be the presenter and the MC for tonight's program. Dr. Nesreen Sufi is an attending physician and assistant professor of clinical pediatrics at Children's Hospital Los Angeles, Keck Medicine of USC, Gastroenterology, Hepatology, and Nutrition Division. Dr. Sufi completed her residency at St. Louis Children's Hospital at Washington University Medical Center. She continued fellowship at the University of California, San Francisco in pediatric transplant hepatology. As a pediatric gastroenterologist and transplant hepatologist, Dr. Sufi specializes in the care of pediatric patients with liver disease and those who need a liver transplant. She's co-investigator in the Childhood Liver Disease Children Research Network, a research network funded by the NIH to advance the study of rare childhood liver diseases. She's also a clinician educator as well and provides training for pediatric gastroenterology and hepatology fellows at Children's Hospital Los Angeles, Keck Medicine of USC. Dr. Sufi, thank you for your support and participation. We are anxious to hear from you and see your presentation.
Thank you for the kind introduction, Farah. And let me to share screen. And then here we go. Okay, everybody can see the slides?
Yes.
Okay, so we are going to talk about pediatric liver transplantation today, as introduced. First, I'm going to go over quickly what does the liver do. So the liver is a large organ that's located on the right side of the body, under the lungs, basically under the diaphragm on that area. And it's a very vital and it's involved in many important functions that the body performs. You pretty much cannot live with without a liver for more than 12 to 24 hours. So it is very important for survival. And one of the few functions that I'm going to discuss today that it does one of its functions is detoxification. So the liver filters toxins and harmful substances from the blood, including things like alcohol, drugs, and metabolic waste products. It also helps to metabolize nutrients from food, including carbohydrates, fat, and protein. It helps to store and release glucose for energy as needed. It also produces bile, which is necessary for the digestion and absorption of fat. The liver also produces proteins that are essential for various functions in the body, such as blood clotting, immune system function. It also stores vitamins and minerals, such as vitamin B12, iron, and copper, and releases them into the bloodstream as needed. The liver helps to regulate cholesterol levels as well in the body and plays a role in the production and breakdown of hormones. When is a patient deemed that he needs a liver transplantation and a liver transplant is indicated? There is many cases, and I'm going to focus in this presentation on pediatrics. There is a big difference between them, even though there's some similarities, but there's big difference in the breakdown of what's common in pediatrics versus what's common in adults. So in pediatrics, the most common cause that kids need liver transplant for is cholestatic liver disease, specifically biliary atresia. It's usually about 35 to 40% every year of pediatric liver transplants are performed for this disease, which is basically a cholestatic liver disease. And what that means is it's a disease where bile does not get out of the liver and stays in the liver, cannot get excreted, and it ends up basically causing high levels of bile in the body, in the blood, and eventually that causes a end-stage liver disease and cirrhosis. Another indication of pediatric liver transplantation is acute liver failure, and this usually happens with things like ingesting toxic medications or toxic mushrooms, herbs. It could also be high levels of over-the-counter medicines like Tylenol. Tylenol is a cause for acute liver failure if there is an overdose, among sometimes unknown etiologies, viruses, things like that. Hepatic malignancy is another indication for liver transplantation, and this is a tricky part because the malignancy has to be only in the liver and not in the rest of the body for liver transplant to be curative in these conditions. And there is very strict criteria to decide if a patient will benefit from a liver transplant or not in hepatic malignancy cases. Another interesting indication of pediatric liver transplant is certain genetic diseases. When you cure the disease with replacing the liver. So there's certain babies are born with conditions that cause them to have metabolic crises and brain problems because they're missing an enzyme or there's a defect in the metabolism of certain pathways. And when you actually replace the liver, you basically fix that problem and give them much better survival and reduce their morbidity and their brain damage with these in these particular conditions, such as urea cycle defects. And next, I'm gonna go over what's the patient journey. So once a physician decides that I'm concerned my patient's liver is not doing well, I want to refer them, I want to send them to get a liver transplant. How does that look like from there? So the first step is usually referral to a pediatric liver transplant center. These referrals can be from outside the center, sometimes from inside the hospital. You'll have subspecialty clinics that they see these patients, or sometimes you'll have a patient come into the ER with things like acute liver failure. And at some point, a decision is we need to refer this patient for a transplant center to get a liver transplant evaluation. The liver transplant evaluation is the next step where a patient gets a lot of blood work and gets assessed by multiple points of the team, multiple personnel of the transplant team to decide if a liver transplant is in his best interest or not. The third step is after all the team members got their assessment, we got all the information we want from imaging and blood work. There's usually a selection committee meeting, and the team sits together and decides and discusses the case. And because these are very complex cases, and it's never a one-person decision. The team decides together if we think that the patient's best interest is to be listed for a liver transplant. In the United States, once that decision is made, the next step is get an insurance authorization for the transplant, and at that point, you can list for a liver transplant. We're going to talk a little bit about what happens after that. But let's say he's listed, an organ is available. We'll talk about the surgery, the hospital stay, life after a liver transplant, and what do we watch for and what's the possible complications. But where, if a patient is deemed that he needs a liver transplant and is listed, where do organs come from? There's two. You can either get a living donor, there's two ways, a living donor or a deceased donor. Living donor can be related, like a mother, or sometimes there's altruistic unrelated liver donors. And this picture here in the slide kind of cartoon of what does that mean. In kids, usually you can remove the left lateral segment from an adult and transplant that piece in a child. In bigger kids or in adults, when they do living donor transplantation, they use the right segment of the transplant. Another source of organs for kids who need a liver transplant is deceased donors. And in that case, you can either do a whole or a split. The criteria that we use to deem if a patient is, if a donor is a good fit for the patient, there's a lot of criteria. There is the weight, there is how healthy the organ is. And the other thing is we match the blood type. Here's a table of how that matching goes, because somebody could be healthy, a relative that's healthy and willing to donate, but if the blood type doesn't match, or the health and the lifestyle of the donor doesn't match, or size, those could be barriers to donation. And I wanted to include this diagram from a government website saying one person, this is for deceased donor, one person can donate up to 8 life-saving organs. And I want to highlight that for the liver, it could actually, so if you count all of these organs, there are 8, but if you actually do a split, you can make this number go up to 9. And split liver is not done in all transplant centers because it needs a very specific technique that the surgeons needs to be comfortable and good at doing, but it's something that we as a community, as hepatologists, we always advocate for doing more of, especially for our patients, for our kids. The more that surgeons are there comfortable with split livers, and we will get more organs to transplant the pediatric patients who a lot of time they only need a small piece of liver to survive. So here's a little bit data about deceased versus living donor, and this is from the OPTN SRTR, the annual data report. And so we can see here on these graphs that both patient survival and graft survival is slightly better in living donor than deceased donor. This could be due a lot of reasons, but some of them are you have a lot of control over the surgery. When you have a living donor, you can decide, the time, you minimize something called ischemia time, which refers to how long is the organ outside of the body. And the longer that time is, the more inferior the graft would be. So you can control that duration because you have control over where is the donor, where is the recipient. So there's factors like that can optimize the surgery. The other thing that I think plays into this is when you do a living donor, you can do the surgery way sooner than what you would have done if you have to wait for a deceased organ. And sometimes, unfortunately, our patients have to wait for a long time before they have an available organ. And so the sicker they are going in the surgery, the sicker they are coming out of the surgery, and that can also affect their survival and the graft survival and outcomes. Here's another slide that pretty much says the same thing with more timely data. So this is 2020, and we can see that in the left graph among pediatric patients and living on the left side and the deceased on the right side. And we can see that the living donors overall, they do better, especially more with the years going forward and more expertise in doing this surgery compared to the deceased donors. And now I'm going to talk a little bit about the OPTN and the UNOS, just to kind of explain how does the organ allocation work. So how do we know which organs goes to who and how is the order happen? So OPTN is responsible for managing the national transplant waiting list, and it develops policies and procedures for organ allocation and monitoring transplant programs to ensure compliance with the federal regulations. UNOS, on the other hand, is a private nonprofit organization and operates the organ procurement and transplantation network under contract with the federal government. And basically how we end up, how the organs end up being allocated is really tied to how sick the patient is and how far is the organs from possible patients that need them. How far is the donors from possible patients that need them. Here I have a graph of something called the MELD score, which is a score more made for adult patients. And there's something that's kind of equivalent to it. It's called the PELT score for pediatric patients. So MELD is studied way more because those numbers of patients who need liver transplants there's way more of those in the adult world compared to the pediatric world. And there is a correlation between this score and your risk of mortality. So here on the right, we see the 3-month survival, and on the bottom, we see the MELD score. And the higher the score is, the less the survival. So that translates into the higher your score is, the higher you go on the list. The acute liver failure, if you fulfill certain criteria, doesn't go under this score at all, and you go on the top of the list because the mortality is way higher in a matter of days. And so the OPTN makes policies and guidelines on how to basically allocate the organs based on how sick the patient is, where the score is, how long they've been on the list, and how far they are from possible donors, and how to kind of geographically organize that. And in February in 2020, shortly before the pandemic, there was a new liver distribution policy that was based on acuity circles. This has replaced something before that was called service donor areas and region-based boundaries. And this is because certain regions had to wait for a long time compared to other regions in the same MELD and PELT score for the patient. So we're trying to kind of make things a little bit more even and fair for patients wherever they live. And that's how this policy change, this is why this policy change was implemented. One of the outcomes of this policy change was to have patients' liver go to pediatric livers go pediatric recipients, which was a change from the policy before. And this has led to an increase in deceased donor transplant rates and decrease in pre-transplant mortality rates among children. Actually, this is what this slide shows here. This is if we look at the months since the acuity circle, and this was in 2021 where they made this graph. And so we can see here on the top side that patients less than 18, they were having the deceased donor transplant rate in this patient population was higher. And below we see that sicker patients, so status 1A, and then pink MELD and PELD 37 and higher had slightly, the 1A had a significantly higher, and PELD MELD 37 and higher had a slightly increased rate after the implementation of the policy. Now I'm going to talk a little bit about the surgery. How am I doing on time? My clock here went away. You know, Farah?
You have about 7 more minutes.
Oh, okay.
You're good, yeah.
All right. So the surgery takes, once an organ is available, the next step is the surgery. And the surgery takes, I tell patients, 6 to 12 hours. And that's because we see here the liver is an anatomically very complex organ. You have an artery, you have a vein, portal vein from below, you have a bile duct, and then you have veins coming from the top. And all of these vessels in pediatrics are extremely tiny. And our talented surgeons, you will see how the surgery goes. They look pretty much like microscopes to make sure they're doing these connections as accurate as possible to minimize any complications and get the best outcome for the patient. And here I have an image for what a possible whole liver transplant would look like. So we see how all the stitches and the connections were below and from the top. And on the right side, that's what we mostly see in kids and babies. Basically, they not going to fit a whole liver in there, so they get a left lateral segment. You connect the bile duct of the segment and to a piece of the intestine, because a biliary connection at that edge is so small and it won't really survive a surgery. So you connect to a piece of the intestine, and then you connect the artery, you connect the portal vein, and they connect the vein on top of the graft to the main vein in the body. The hospital stay is usually a few days in the ICU, and then the rest is on the floor. I prepare the patient, say this is how they're usually going to look like after the surgery. They're going to have a big scar. They're going to have a tube out of the abdomen to monitor for bleeding. They have a lot of lines. They might be intubated or not, based on how their lungs are ready. And again, the sicker they are going in, the sicker they are afterwards, and it's going to be a little rougher afterwards. But overall, the outcomes are good. The ICU stay and the hospital stays basically has a lot of blood work to monitor liver function and prevent complications, a lot of ultrasounds. We start them on a lot of medications to prevent rejection, so high doses of immunosuppressants. We put them on pain medicine to minimize their discomfort. And as the days go by, they need less medicines, less lines, and usually the hospital stay on average is 14 days. After discharge, also there's frequent visits, frequent blood work with the transplant team, and that also gets spaced out. So most patients after first year of transplant, they are seeing us once a year. They get blood every 2 months and they're on one medicine twice a day. They enjoy pretty much normal life, minus you got to be really careful because you're immunosuppressed, and usually the immunosuppression is needed for the rest of their life. So they need to be really careful, like not doing anything, you don't need to be going to a petting zoo or exposing yourself to sick people. But other than that, they pretty much enjoy a very good quality of life after a transplant. The outcomes obviously will depend on different variables. So certain underlying conditions you can have better outcomes than other ones. Overall, as we said, the sicker they are going in, the sicker they will be after, but eventually most of them, they do pretty well. And the quality of the donor liver plays a factor too in the outcomes after transplant. The other factor that we struggle with, especially with kids who got a transplant when they were babies and now they're teenagers and they don't remember how sick they were, is adherence to the medication and follow up with appointments, because they feel like, well, I feel fine. Why do I need to take this medicine? They don't remember how sick they were. And we struggle with, no, you need this medicine. Otherwise you would reject them. Their compliance and adherence to the medication and follow up with our recommendation on blood work also affects the outcome and the graft survival. Here's some more data. So pediatric liver transplants here in the last about 10, 12 years. Deceased are about 500, live-in is here below. And here's by the recipient age, the majority of the highest group of patients, age group in pediatrics that receives liver transplant is between 1 to 5. And then we have a pretty substantial amount also that do receive liver transplants when they're infants less than 1 year. And again, that's because most of the transplants are because of biliary atresia, which is usually something that they need to be transplanted for in infancy. Here's a graph about patient survival. So pretty much 90% is the patient survival here, and there's a little bit of variation, and this is up to 5 years. And that doesn't mean that they're only going to live 5 years. That means if you track it to 5 years, 90% of them are still alive. And it's usually the toughest part is this first year, and you pretty much do pretty well after. This is all summary without breaking it down by age. Here, I wanted to show a little bit of breakdown of the etiologies. So again, biliary atresia, if we look at 2011, 207 out of 260. And this is pediatric candidates for liver transplant on the wait list. So biliary atresia is pretty much the biggest category, 32, 34% now. And then the second slide, we're going to talk a little bit about the possible complications after liver transplant. So there's short-term complications. And so this is what we watch for in the hospital stay after transplant. We look for any clots or any bleed in all these vessels that were connected. We look for any biliary problems with the biliary connection. And the earlier we find these, the more successful we are at treating them. And that's what we're very diligent at observing and watching and monitoring and catching these complications as early as possible. Rejection is another possible complication. The liver is more forgiving, because usually if we have one episode of rejection, we're successful at treating it. It doesn't really affect the graft function. Well, if you compare it to organs like the heart or the kidneys, every time you get rejection, you lose some of that function of the organ. The next one is infection. Again, as we said, because you're immunocompromised, that increases your risk of infection. You need to be really careful. Every medicine has side effects, and patients are different in how they respond to different medications. PTLD, post-transplant lymphoproliferative disease, is another possible complication after transplant. And that's basically like an early form of lymphoma that happens when you suppress the immune system. And so that's another thing that we watch for with blood work and exam. And very rarely, some conditions like autoimmune hepatitis or primary sclerosing cholangitis, you could have recurrence of the underlying condition that you were transplanted for. This is something we see way less than the adult colleagues. And organ failure is very rare, but it's also a possibility. Here is a graph of outcome by diagnosis. So there's a little bit of variability. So hepatoblastoma here So the first graph, let's start with the graph. The first graph is patient survival among pediatric disease donor transplant recipients by diagnosis. The green here is hepatoblastoma, which is a liver cancer that affects childhood, and it's the one who has the least survival, while metabolic kids, which is the kids we were talking about, if they have an enzyme defect, that's usually cured by liver transplant. They enjoy a better outcome because you think about it, they don't really have a liver disease. So their surgery is usually less complicated than kids who have cirrhosis and a lot of fibrosis and a lot, a sick body overall. So there is a range, and your outcome can depend, the patient outcome can depend on the underlying diagnosis. So the graph below is pretty much similar. Hepatoblastoma is the worst, and you have the metabolic to the best, and that's looking at the graph for survival versus the patient survival on the top. I just wanted to show here, I think I'm almost done, but this just looks at how many patients are on the wait list every year. And even though when you compare these numbers, it's slightly less, but it's still pretty substantial. This is a lot of patients, are pediatric patients that are on the wait list at the beginning of every year. So 500, 400, 400. So even though we transplant about that number, there's as many patients kind of being enrolled in, and some of those stay and carry over from a year to year. So there's definitely a scarcity of organs. And the reason why do we have low donor rates is the jury's out. There's so many different reasons, and this gets very political, and there's a lot of articles about it because the policies are different for donation from a different country to another. So there's always in the meetings, there's always talks about how can we have more bigger donor pool. And these are, I've listed here some of the reasons that people mention as a reason for the scarcity of organs. So things like cultural, personal, religious beliefs, lack of awareness of how important it is to be an organ donor and how many people are sitting on those, especially kids, and then logistic factors and how far is the organ from the patient. So there's a lot of talk about opt-in and opt-out because some countries you opt out if you don't want to be a donor. And so if you don't say anything when you renew your driver license or whatever, you're presumed to be a donor, while like in the United States, it's an opt-in. You have to decide, oh yes, put me in. And so some people say that could be an issue while we have less organs available than other countries. And then the last point, some people say like, we have a distrust in the health system in general, that people are a little bit worried, which is why I think, making talks like this and kind of filling that gap and talking with a lot of people about how this outside of those who are inside, the medical system is very helpful to raise that awareness and trust. That's pretty much it. So these are some take-home points. Pediatric liver transplant is life-saving for the patients who need it. Lifelong monitoring medications are needed for optimal outcome. Possible complications are either post-surgical or related to the immunosuppression or the underlying diagnosis. There's not enough organs. There's way more patients on the list than patients who need organs available, and there's a huge need for more donors and to increase the awareness. And overall, patients enjoy great prognosis. The majority of them enjoy normal life and activities after transplant.
Wonderful. Thank you so much, Dr. Sufi. Excellent presentation. In addition to the questions that I had sent before, there were a couple that came through my phone that I will mention them when we have when we start our debate or conversation part. So now we're going to start the second half of the webinar. This year we made this change that we will have one presentation at the beginning of the program so people understand the issue, what that disease is, or in this case, what does it mean to do a transplant on a newborn child. And then at the second part of the conversation, we will have a roundtable discussion with our expert guests who will talk among themselves and bring more issues up that maybe we couldn't cover in our presentation. So in this part now, we have some doctors. I would actually already met Dr. Sufi, who is going to host this section. I'm going to introduce our other experts that are with us today with much appreciation for them giving their time to us and bringing this information to our audience. One of our experts is Dr. Kambiz Ehtesami. He is an assistant professor of clinical surgery, Department of Transplant and HPV surgery at Keck Medicine of USC. He is a director of kidney transplantation and assistant director at liver transplantation at Children's Hospital, Los Angeles, which we all know as CHLA. Dr. Etesami received his medical degree from the State University of New York, Downstate Medical Center College of Medicine. He specializes in adult and pediatric liver, bowel, kidney, and pancreas transplantation. He additionally performs HPV, which is a surgery that relates to the liver, pancreas, and biliary systems, incorporating both traditional and minimally invasive techniques for a variety of benign and malignant conditions. Dr. Etesami's medical interests include the expansion of organ availability, which we just heard that there is a really scarcity of organs available. So his interest is the expansion of organ availability and transplantation with a focus on living donation and maximized utilization of extended criteria organs and management of advanced hepatobiliary and pancreatic neoplasia. I hope I'm pronouncing that correctly. Dr. Etesami is an active member of the American Society of Transplant Surgeons and is an associate fellow with the American College of Surgeons. Dr. Etesami, welcome. We appreciate your participation. I'm going to introduce the other doctors and participants, and then we will have the discussion. So I want now to introduce Dr. Elena Gutierrez. She is a medical director of Pediatric Liver Transplant Program and an assistant professor at the Division of Pediatric Gastroenterology, Hepatology, and Nutrition at the University of Alabama at Birmingham. Dr. Gutierrez received her medical degree from St. George's University and completed her fellowship in pediatric gastroenterology, hepatology, and nutrition at Mayo Clinic, and her pediatric transplant hepatology at Children's Hospital, Los Angeles. Dr. Gutierrez's interests are liver transplant, acute liver failure, autoimmune hepatitis, and non-alcoholic fatty liver disease. Dr. Gutierrez, welcome. Thank you for your participation. From the long distance you're with us. I know it's later than your part of the United States, and we really appreciate you participating. Thank you. Our other participant is Nurse Anna Lily Padilla. She is a living donor transplant coordinator at Keck Medicine of USC. She earned her Bachelor of Science and registered nurse degrees from Mount St. Mary's University in Los Angeles. Ms. Padilla has worked at Keck since 2009. She has worked in several units, starting with the abdominal transplant ICU unit, and now, of course, she is the living donor transplant coordinator. Ms. Padilla was raised, I think this is important, and I wanted to make sure I include this in her bio. Ms. Padilla was raised in Mexico in a small farm. She came to the United States at the age of 19, learned the language, and pursued a career in the nursing field, which is the field that she loves very much and feels blessed to work with world-famous surgeons such as Dr. Genick. And now she's able to facilitate life-saving surgeries. Anna has been married for 22 years and has 2 daughters, both already in college. Her oldest, who is 21 years old, will graduate this May from Mount St. Mary's University, just like her mother, with her bachelor in nursing. Ms. Padilla, welcome. You already have accomplished so much. Congratulations for a life lived well. Tonight, we have a special guest with us that I believe will add so much more to our conversation when she shares her experience, her living experience. I am happy to introduce Ms. Erin Faust, whose daughter Morgan was born with biliary atresia. Erin, her husband John, and Morgan lived through very difficult times before Morgan was diagnosed with BA and finally received her liver transplant in 2020. Erin will share her story with us and our panelists. Unfortunately, or fortunately, Morgan is playing sports tonight, so she couldn't be here. She is a very active young lady. So at this point, Dr. Sufi, will you please start the roundtable conversation?
All right.
Anywhere you want to start asking questions from our
Okay.
mother here, Erin, or I have some questions with me. I can mention some of those, or if you have them, you can. Hi, Dr. Etesami.
Hi, good evening.
Good evening.
Hello.
Yeah, one of the questions that I would like to start with that I think you received from and you shared with me is the challenges. What are the most difficult challenges that we all face in liver transplant? So I want to see what Dr. Adesami and what Dr. Gutierrez, what would you say the biggest challenges in the pediatric liver transplant, in your opinion?
Dr. Gutierrez, I'll let you go first and then I can say my part.
Sure. So I think one of the most difficult challenges, at least for me, is just, and that comes with the beauty of pediatrics, is the pain that sometimes you see with the in the families, right? Like when they first come in and they don't know what's going on and they need guidance. It's challenging, but it's also the beauty of what we do, that we're there to help them out, but at the same time, you know that it's a rough path. You know, it's a lot that they're going to have to undertake, and sometimes it's, you know, difficult for some to overcome. But and then, you know, obviously the worst challenge is when you have a bad outcome, especially again in pediatrics, when you really get to know these patients and you see them growing up, and then if something happens, it's quite difficult for all of us.
Yeah.
Yeah, I concur with that sentiment. I also think obviously when you deal with pediatric patients who are some of the most vulnerable members of our society, the stakes are at least for me are higher from an emotional perspective. And at the same time, you have special challenges of doing operations from a surgeon standpoint that require a special skill set that's not readily taught, at least at the current state of transplantation, but it's something you pick up as you extend your career within the field. So that is something that I hope to see changed in the future, and that the training regimen comes to a place that's more focused on dealing with these patients.
Yeah, I agree, especially with like the specific things that pediatric patients suffer from. That I feel the organ shortage is just breaks my heart to see the kids getting sicker and sicker and sicker. And then there's definitely the particular surgical challenges, because these kids are way smaller than adults, so everything is smaller. So from a surgical perspective, as Dr. Sami has mentioned, the other thing that I also see is like when we get sometimes all of these kids with transplant really early. And so it's really hard to like the long-term management and seeing, you know, new problems come up as they're getting older. The bigger one is compliance, because, you know, these teenagers don't remember how sick they were when they were babies, and you really need to take their medicine. So that's the part is really challenging for me. So I'll go down with more of the questions that we received. In addition to jaundice, what are other symptoms of liver failure in infants and older children? Dr. Gutierrez, you want to cover that one?
Sure, yeah. So what we see as part of liver failure is development of ascites, so accumulation of fluid in your belly. Sometimes, and what we worry the most is altered mental status. So when the baby or pediatric patient becomes altered, so they could be sleepy, irritable, combative. You could also develop bleeding, as Dr. Sufi mentioned, the liver synthesizes a lot of different proteins that you need, and some of them are the ones you need to do clotting, so you could potentially bleed also. Yeah.
And there's
May
another
I-
question. Oh, go ahead.
May I just ask Erin, how was it with Morgan? What symptoms did you see?
We were real fortunate. I mean, she was diagnosed with biliary atresia when she was a baby, but we didn't know it until she was about a month old. And we went in just for, actually, she was almost 2 months old, actually. And we went in for a 2-month pediatric, just her wellness visit. And we were new parents. We didn't know anything about it, but she had this beautiful olive skin, and we thought maybe some of it was from my background. And our pediatrician looked at us and basically said, this is a problem. And so as new parents, we didn't really know what was going on, but within 48 hours, we were rushed to chalk, and they were running my baby through all kinds of things. And so we were just, new parents trying to figure all this out, and with limited medical background between my husband and I, and not being able to help. So that was a stress for us in the opening months of our child, and not really knowing what to expect, and then to be told of something we'd never heard of. It was overwhelming, to say, to put it mildly. And she had the Kasai procedure. That was the first of 5 surgeries that she's had. And when we were told, it was 2 to 3 hours, but we would get updates. That was the longest 8 hours of my life, next to her actual transplant 2 years ago. Again, new parents not really understanding what's going on, and it was stressful. I mean, to learn about the liver and what it's done over the past now 11 years has been more education than I have ever experienced when it comes to just the human body and the importance of the liver. So there are stresses that come along with it, and I think both my husband and I, in the process of it, we always had a real positive outlook. We had an amazing family of doctors that were working with us. They didn't want to force us to do things that we weren't ready for. We didn't know what to do, so we had all kinds of options. We handpicked our GI team. And I stood up for my kid, and there were certain doctors that were pushing for one thing, and I was like, you guys need to back off. And we handpicked our GI who understood how we were, and he worked with us. In fact, we didn't go up for liver consultation until Morgan was 7, I think 7.5, and she had a transplant literally a year later. So yeah, it's stressful, but I think we can also look back and go, wow, look at what we as a family have been able to endure. And there's nothing that's going to break us apart if we've gone through this kind of trauma. Our family is solid. And again, it's through doctors like you that have had the patience to work with the parents and the nursing staff. Oh my God, I wish if I ever have to go in the hospital, I want a pediatric nurse. There's just something about pediatric doctors and nurses. So, to you guys, hats off, and certainly thank you for what you guys do for our little people. Because, not to quote that goofy song from the 80s, they are our future. So you're keeping it bright for us.
So this is very good to hear from a patient's point of view. And I can testify that Morgan is, when you see her, she's just a normal kid. She's constantly running around, playing, just very, very happy child. Unfortunately, the picture we had of her was when
she was just getting over the flu. So
yeah, that was a good picture. So Dr. Sufi, I'm giving it back to you.
Yeah, no, it's very heartwarming. I love when I hear that how well they're doing, because we're in the hospital, so we always see them when they're sick, and then like once a year. So it's always amazing to hear when they're doing so well outside in the world, and that we played a small part in this big journey. So I love that. That's amazing.
That's no small part, though. You understand? That's the biggest thing that's happened to us.
Compared to what you guys do, I can only imagine as a parent, having your child go through that. That's one of the hardest things a person can go through. So,
I do commend the parents, because we do see parents when they come for a donor evaluation. I see their pain, I see their suffering, their most loved treasure is in danger, and they're like very desperate. And they'll do anything and they just want their baby to be good. And it's kind of hard sometimes when, they're not donors or for one reason it's not safe to proceed with the donation. It's hard for them to understand, but, we get to see a lot of very, very successful stories but I get to see your pain and I commend you for staying strong and being there for your baby girl. And it's amazing what a parent can endure for the love of their little ones.
So Anna, there's actually a question for you. For living donors, do they have to be related to the recipient of the donor? There's more like a particular situation. I don't know if should I read like the whole.
I can just quickly say there was a mother and father didn't match that they wanted to donate to their child. And so they brought grandma and grandpa and they didn't match. So they just had to be on the waiting list. Is it normal that nobody in the family, the adults, don't match or are not suitable?
It happens often, but now we have different options. We have an option of doing a donor swap. So if the intended donor for that recipient is not a match, we can look for an alternative or another donor that is not a match for their intended recipient as well. We already have one successful, donor swap, very successful. So there's more alternatives out there. So even if they're not blood compatible or not size compatible, they still have definitely, other options that we can explore.
Oh, that's interesting. I didn't. So is that a kick program? I didn't know that's like a local, or is is multiple centers doing that?
So the one that we did, it's actually CHLA and KEC. It was a swap between both our centers. Yes.
That's super cool because that will definitely help getting more kids transplanted once we widen the donor pool.
Yes.
All right, so let's see what else is here. How do you test for compatibility of donor and recipient prior to the transplant surgery? You can take that too, Anna.
Yes, sir. So we first send them to do blood typing. That's the first test. And then if there's additional donors, we test the other donor, next donor until we find the suitable donor. But if for any reason they're not compatible, we look into this other swap alternative. Let's say they are compatible. The next step is to do a full evaluation where we do a lot of imaging and consults and labs and it's a very comprehensive donor evaluation and that's my role to facilitate and kind of guide them through the process. And if they're a match, then we proceed with scheduling surgery. And it's fairly quickly, especially if it's a CHLA baby.
Yes, this is when we have the luxury when that happens to like pick a date and
Yes.
when it's a deceased donor, we don't know when that
Yes.
is going to be available. Dr. Adesami, question for you. How long will it take for the liver to grow to its natural size in the living liver donor and the recipient?
The liver regenerates pretty quickly, actually. Usually by 3 months out, it's accommodated the body needs of both the donor and the recipient. The exact rate varies. There's a lot of variables at play. Obviously, we start out by gauging how much liver to take so that the donor has enough remnant liver so that even without having regeneration, they're not at risk for liver failure. So we don't rely on the ability of the liver to regenerate for the donor to donate. We practice so that we leave them with enough such that they are going to be fine regardless. Same for the recipient. We always do our tests, measurements, anatomical studies to determine how much liver we get for a particular patient so that they have enough liver to function normally. But the liver does grow with the needs of both the donor and the recipient. So usually it's within 90 days is the time during which most of the regeneration takes place.
Okay, pretty fast. Doesn't take a long time.
Pretty fast, yes.
And-
Liver diseases hereditary. If, for example, a mother has liver disease, will the child have the same issue when he grows up or she grows up and have a child of her own? Does it run in the family or it just happens?
So
You
this,
want me- Okay.
yeah, Dr. Gutierrez actually can answer that.
Yeah, so I think there were some questions. So it depends on the disease, right? So there are some diseases that are hereditary, that you have certain mutations in your genes. Usually you require them, depending on the disease, to acquire it from mom and dad for you to develop the diseases. And some of them, just one mutation, you could have the disease. But these diseases are quite rare, you know. We still see them, but we have a skewed population because we see those kids, right? But other conditions like biliary atresia, that is not hereditary, right? So if somebody has biliary atresia, I am not gonna pass it on to my kid.
Yeah, such the metabolic conditions, and yeah, there's some things that are still also, there's a lot of research going on. So even though biliary atresia, like Dr. Gutierrez said, is not hereditary, well, what exactly causes it? There's so much research going on because these diseases are so rare. Biliary atresia occurs 1 in 12,000 in the United States. So it's even hard to even do meaningful research in one center. And that's why, you know, there's this consortium trying to pull as much, you know, patients and enroll them and follow them over time and see what factors are similar, what's not, what can affect the outcome, what can we learn about the past, and the more numbers we have, better for these research studies. There's so much going on and so much to learn and so much we don't know.
I heard a lot from people who their children had a transplant and they were taking care of them, medication and all that. And now the kids are going to school and parents are going crazy because they don't think the children will stay with the medication and what they have to do to keep their liver
Right.
healthy. College, we know, comes with a lot of, sometimes comes with drinking, young kids, and that's very bad for their liver. The question I had here was that autoimmune hepatitis, does it always end with liver transplant or can they just live with it?
So in pediatrics, it's not a common cause of transplant. Some kids will need to, there's different types, and some types are more severe and more progress to cirrhosis faster than others. A lot of patients, they just take their medicine and they don't get cirrhotic, especially if they were lucky enough for the disease to be caught before much cirrhosis or much fibrosis would happen. The tricky part in a lot of liver diseases is unless you're so sick and you lost so much of your liver function, you're not going to have symptoms. So that's the problem with autoimmune hepatitis. Sometimes, you know, the diagnosis comes like somebody got some liver enzymes, you know, the pediatrician or the kid went to the ER because the stomach hurt and they did the liver test and was like, oh, your liver enzymes are high, and that brings it up. But if they're lucky and we caught it early, there's not much fibrosis, they usually do pretty well, except the kids who have these subtypes that are more severe. So I don't know the exact number, but I would say like it's a very small percentage of kids that need liver transplant. Would you agree, Dr. Gutierrez?
It is. So I know that the total for like the US, I think it was like, I was reading 2021, it was only less than 5%. And that's just adult and pediatric combined. So it's very little, yeah.
PA is the major cause of liver transplant for kids, or yes?
Biliary atresia, is that what you said?
Mhm.
Yeah. Yeah, about 40%
Yeah.
of pediatric liver transplants are for biliary atresia. And sometimes that's early when the Kasai doesn't work, and sometimes that's later on. I know one of the questions that were on the paper was somebody's daughter had biliary atresia and they had the Kasai and she's doing well. What's her chances of needing a transplant? And the research earlier was more sadder. Basically, it was saying a lot of them eventually they will transplant, but things are looking more optimistic right now. So it's like a pretty much a good percentage that might not need a liver transplant. So I think it used to say like you'll wind up with 70 to 80% total biliary atresia will get a liver transplant. That's when I started my training, that was the numbers, and now it's more like 65% total. So that's less than before. So we're getting more like closer to the half, and hopefully, you know, biliary atresia is tricky because also if you diagnose it early, do the surgery earlier, you can have a better outcome, but there's also a range. And so yeah, but it is, to answer your question, it is number one. It's the number one cause. And over time now with the adults is that we're having more, you know, alcoholic hepatitis and NASH, non-alcoholic steatohepatitis has become more a player in the adult world. And unfortunately, we're seeing more of those getting sicker early too in kids. It's still not competing with pediatrician on the numbers, but unfortunately, we're seeing kids who are having cirrhosis because of non-alcoholic fatty liver disease in the pediatric age.
You all talked about difficulties of doing transplant on children. I feel personally, I'm now a grandma, and lucky for us so far, we haven't had any kind of disease like that. But I feel for you as a doctor and a nurse, just to be able to calm down the family and make sure they understand that even though this baby is small, this child is still so young, that this is the best thing to do for them. It must be very difficult on you all.
Yeah, maybe I can take that on just briefly. It's definitely true because you're talking about, from a surgeon's perspective, talking with parents regarding a very, very large, prolonged, and potentially morbid operation with a lot of risks associated with it. Risks that people may be familiar with in terms of just any operation like bleeding, infection. But when you're talking about a liver transplant, and then when you're talking about doing it on a very small infant, those risks are compounded. And then you're talking about doing it on someone who's, you know, a newborn potentially, or a very young infant. So, but yeah, I mean, you just tell them, you know, at least my approach is to be very honest, very frank, not to scare them, but to be forward with them in terms of what to anticipate, and the fact that this is the child's best potential route to recovery. And that doesn't absolve you from the risks of the operation. But I think being frank with the family, letting them know about the potential complications ahead of the time is generally well advised. And most of the time, despite being scared, most parents, most caregivers, most family members are pretty understanding if you take the time to explain it to them in plain terms.
Yeah, I think I agree. I mean, it's really education, and education is power, and being transparent. I think parents, I mean, like that, you know, to hear what could go wrong, but also what could go really good, and the outcomes afterwards. And it's really a team approach. I mean, you really need all members of the team, you know, nurses, dietitians, surgeons, hepatologists, program coordinators. Everybody plays an important role, and to support them and to educate them, and to be patient, right? Like, we have to be patient. We know that we're going to have to say things more than once, to explain it again, to draw it. And again, I've always said education is power. And if you educate your parents and the patients, they feel empowered to make options and to understand things better.
Yeah.
I agree. I agree with that statement. As well as nurses, we witness, you know, their suffering and pain throughout the day and night, sometimes when they stay on the bedside with their child. And when our doctors come in and explain, I think I agree that being very honest with, you know, the parents gives them a sense of like, okay, there's a possibility, and I trust my doctor. I know that there's could be the good side, you know, a good outcome. I have to be realistic, but they also feel supported by the entire team. It takes a team approach, definitely.
You know, Erin, still, when she talks about all Morgan's had gone through, she still tears up. And it's been very traumatic experience for everybody in Faust family. Morgan has a younger daughter, the sister, but she's fine, right, Aaron? She has,
Yeah, no issues. Morgan had calcification on her heart when she was in utero, and so we did the amnio and stuff when I was still pregnant, and when Peyton was born, we went ahead just to rule it out. And she's got the worst. She had a partial tonsillectomy, and that was I don't know if that's hereditary or not, but has nothing to do with what Morgan was. And I know sometimes that can be a concern for families that they've got one kiddo. I mean, we went to a walk and it seemed like almost all of the other kiddos out there, they were only children. And my husband and I, we both made a very conscious decision that when Morgan was stable, we wanted a second child. And so when Morgan was 2.5, Peyton came along, and Morgan had been great. She, everything was stable. She would have bouts of ascites, and our doctor's like, all right, well, let's either come in for Lasix or treatment. She was on a diuretic, and then we had take home Lasix just to kind of keep things under control and manageable. And there wasn't any concern for us at that point in time. We want a second kid, and I think it was probably one of the best things for our family because they're best friends. And Peyton looks up to her big sister and sees what she was 6 when her big sister had a liver transplant, and sees, if my sister can do these things, so can I. So I think Morgan is, she's kind of a trendsetter for us. And we look to her as a reminder of, hey, if our baby can go through that, there's absolutely nothing that our family cannot endure. And we didn't shy away from that. But I also understand for the families, that's a lot to have a kiddo who's in and out of a hospital. And we've been lucky. I have to admit, we have been a very, very fortunate family that she had the surgery, like I said, at 2 months. She had to go in for coarctation of the heart when she was at 6 months, then angioplasty on that, and she happened to also develop a hernia, an inguinal hernia. So we had all those little things, and then the liver transplant. But we've endured it all, and it's amazing what that kid has gone through. And you look at her now, and you would have absolutely no idea that she's a transplant kiddo until she'll show you her battle scars, and she's proud of them. And I'm in awe of her every single day. She drives me nuts because she just turned 11, but I'm in awe of her at the same time.
That's the job, to drive us nuts, right?
Hey, puberty is real, guys. It is real.
The only other thing I want to quickly ask is that Dr. Sufi, you mentioned about 2020, in the year 2020, something changed about the way they distribute organs. Was it good for California or bad for us? Are we getting more or less?
I think Dr. Adesami might have a better overall, because I'm like zoomed in on kids. And if you look at the numbers, it says, well, the rates of kids is higher getting, but I don't know about in California in general. What's your feeling with adults and all of that? It's hard to.
Well, I think it really depends on where you are in California. So the current system is center dependent. So if you are at a transplant center, and it's really different between adults and pediatrics. For us overall at USC and at CHLA, it hasn't really made much of an impact one way or the other, because we just have very sick patients that end up needing transplants, regardless of which way you calculate the equations. A lot of them are near the top of the list. So, but there are other centers in California and across the country that have had variable impacts. So, but I think one way, again, to negate the effect one way or the other is to have a robust living donor program that, when you have the capacity to do these cases as living donors, you are less impacted by the availability and allocation of deceased donor organs. Because that's an internal process, the living donation. So again, just in summary, the impact for us hasn't been large one way or the other, but it's dependent on where your transplant center is.
Yeah, that's, I work a lot with One Legacy, who is the organ procurement for a lot of this area that we live in, and kind of concerned because the head, Tom Moon, always is working with legislators, trying to make sure that everything they're doing is equitable and everybody is getting their share. So yeah, I understand that. So I want to thank everybody for doing this for us. Thank you. This was a fantastic roundtable. I hope everybody enjoyed it and we have received important information. Thank you, Dr. Sufi, for your excellent presentation and emceeing this roundtable. Thank you, Dr. Etesami. I hope you continue participating in our webinars. We really are focusing a lot more on pediatric liver diseases because most people don't even think about that. And also thank you, Dr. Gutierrez. You added so much information to this discussion. We appreciate your participation from long distance. Thank you, Nurse Padilla. Your input is of great importance and interest to our patients. I know I have been a patient in hospital. I know when we look at our nurses, we look at them like they are there to really help us. And when a nurse is so good that it just gives you peace of mind and you know you're in good hands. Thank you, Erin. I'm sorry you had to endure some hard times. We and I had talked before, but we're very happy that Morgan is happy, full of energy, and doing great. I also want to thank Albireo Pharmaceutical for their exclusive sponsorship of this webinar and for helping us raise awareness of liver disease. Liver Health Foundation is hosting an in-person walk in Santa Monica on September 23rd from 8:30 to 12 noon. Please register to walk with us in support of liver patients. This walk is a family and community-friendly event with face painting, balloons, music, breakfast, and more. To register, please visit our website, walkforyourliverla.org. And we are on all social media sites. We announce our events, programs, and news that we get from different medical centers on our website and medical and social media outlets. So please visit us. Thank you to our panelists. Thank you to our audience. We hope the information our audience received tonight is helpful to you. I look forward to seeing all of you in May when we host an informative webinar on hepatitis. Good night, take care, and be well. Thank you.